I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
A 58-year-old woman, current smoker, 40-pack year history, with a screening detected small cell. She undergoes resection and ends up being a T1N2 M0. It was initially staged as an adenocarcinoma without mediastinal adenopathy, which may explain why she went to surgery, but was then found to be small cell. Question: what is the best adjuvant therapy? Chemo alone, concurrent chemoradiation, or sequential chemoradiation? And is there a role for PCI? So patient pertinent positives, there's none. This was found on screening. She has an ECOG performance status of 0. Her past medical history is consistent with hypothyroidism, depression. She's had a cholecystectomy, and we'll get to the small cell lung cancer story in a second. Social history: she's a 40-pack year history of smoking. She's currently smoking. She's 4 to 6 drinks per night. She's a former cocaine user, denies current drug use. She has a mother who died of lung cancer in her 60s and a paternal grandfather that had prostate cancer. So this is the pre-operative CT without contrast, and maybe Dr. Ginsberg can walk us through this, and then we have a PET afterwards.
So in the left-hand side, the top, we see the lung windows, and there's a small subpleural nodule which measures 1.7 cm in the right lower lobe. The mediastinal windows don't demonstrate any mediastinal lymphadenopathy. It is somewhat limited for Hyler without intravenous contrast, but essentially we're left with an isolated right lower lobe subpleural nodule with no obvious lymphadenopathy. And the next images demonstrate that there's no avidity in the mediastinal regions, and I believe this is a post-operative PET. So they're post-surgical changes we see on the right-hand side, but no obvious recurrence at this point.
Thanks, Dr. Ginsberg. So bronchoscopy prior to surgery with an EBUS revealed that this lesion was an adenocarcinoma, but then the patient undergoes a right lower lobectomy with mediastinal lymph node sampling that reveals that what was believed to be an adenocarcinoma was now small cell. Made more tissue, better staining profile, 1.7 centimeters with lymphovascular invasion but negative margins. 1 out of 8 lymph nodes is positive, 10 and 12 are, and 1 out of 2 station 7, so into disease. So this is a scenario that has happened before in my practice, an adenocarcinoma, what was thought to be an adenocarcinoma resection. Now you have a resected small cell with into disease. We know the proclivity of these tumors to move not only local regionally, but metastasize. So this patient comes in to see, well, first of all, let me just back up quickly. Dr. Lanuti, surgical data on small cell, is there a role for surgery in very early stage small cell lung cancer?
Absolutely. And there's no randomized trials, but there's sort of prospective and retrospective looks at these. And it's quite clear that in the absence of nodal disease, an incidental small cell that's resectable should be considered to do so after adequate staging, that is brain imaging, invasive mediastinal staging, exonerating the N2 nodes, and if you needed to go after an N1 PET positive node, go after it with EBUS. I'm not sure what they EBUSed here, unless they radial EBUSed down into the actual target lesion, like a navigation bronch. So yeah, there is a role. You just have to choose wisely, and I think that I'm not exactly sure what happened in this case. It looked like a small lesion, and they were gone on maybe PET images to exonerate N2 disease.
Okay. So this patient has surgery, lands in the medical oncology and the radiation oncology office. Always a interesting decision here on the use of these chemotherapy and radiation and how to deploy them in this setting. Remember, this is an N2 positive patient. Dr. Govindan, maybe you can weigh in first. Chemotherapy, if so, what? And how frequently would you give it?
We know that small cell lung cancer is predominantly a systemic disease, and it has been clear that localized therapies alone seldom cure small cell lung cancer. Chemotherapy in the early stage setting, in combination obviously with radiation, cures about 30% of small cell lung cancer. And then relapsed small cell lung cancer is a hard disease to treat in general. So there is a potential to cure somebody with such low volume disease. Chemotherapy is an important component of that. Unfortunately, there's no disease here to follow, but then the fact is that, and there are no prospective studies to show that the adjuvant therapy improves survival. This is one instance where you could, on those few occasions when you don't have data, when you don't have measurable disease, you could make a case indirectly and perhaps tangentially say that systemic chemotherapy is an important component of small cell lung cancer. The arguments we've had in these tumor board meetings have always been, if somebody has had one local modality, i.e. surgery here, does this patient benefit from radiation treatment? And I'm very curious to hear Dr. Karan's thoughts. But I would give this patient, just like any other limited stage small cell lung cancer patient, 4 cycles of cisplatin and etoposide, if possible, or at least carboplatin and etoposide.
Okay. Dr. Curran, your thoughts or your expert insights into the role of radiation post-operatively for an N2 small cell lung cancer, and then I'm going to ask you a harder question about the PCI.
This is what I would consider low volume N2 disease, and 1 out of 7, 1 out of 12 nodes. I'd like to see whether that's microscopic, extracapsular extension, bulky nodes, but incidentally found. This might be a case where I would favor chemo without radiation. If, on the other hand, you had a patient where there was bulky N2 disease and not a good resection or question about how much staging was done, then I might say, yes, we need to radiate. But such a small lesion, if it's truly micrometastatic disease in 2 of 20-ish nodes, I'd probably be comfortable doing chemo only.
Okay, and then PCI.
Again, we're going for cure, I think, with this patient. This patient has a better chance of cure than most limited stage patients. And as you know, median survival time of limited stage patients, is pretty long and getting longer. I would probably off study recommend hippocampal sparing prophylactic cranial radiation. We don't have the data from the energy study comparing hippocampal to non-hippocampal in PCI, but we do have it in brain met treatment, and there's no question it reduces cognitive decline. So that's a technique where we spare the bilateral paired cranial locations known as the hippocampus, and we now have more data showing it reduces cognitive sequelae of radiation.
Great. So great discussions here. So it sounds like for sure platinum-based, platinum etoposide for 4 cycles, holding off on chest radiation, but a strong consideration for prophylactic cranial radiation with hippocampal sparing.